Working all day, staying late. Feels like a crisis that you can't escape. Wondering how we ever got in this shape. How did it get so bad? Austerity, pandemic, a word from Liz Truss, sinking the ship. Well, there's just one thing that you might have missed, and that's a little maths. There's less of us and there's more of them. At the end of the day, it's a simple equation. Don't need to be a brain surgeon to see the problem. You just gotta do the maths. There's less of us and there's more of them. If we wanna make it better, reverse the trend. We need more of us to see more of them. And that's just the maths. It's just the math. In 20 years, consultants have doubled, but we're losing GPs. Now we're all in trouble. Well-functioning health services need strong primary care, but we can't be strong when there's no one left to work there. You just gotta do the maths. Less of us and there's more of them. At the end of the day, it's a simple equation. Don't need to be a brain surgeon to see the problem. You just gotta do the maths. Sort out the pensions, reduce intensity. Scrap a ropey contract that prioritizes the wrong things. And there'll be more of us to help more of them. And that's how you do the maths. You do the maths. Well, I've not got access to my piano right now, so I thought I'd give the guitar a go. It's not my forte, but then neither singing and neither songwriting, and that's never stopped me before. Time, however, is not on my side, and that's the best take we're going to get unless this podcast goes out sometime next year. But it can't. Time waits for no man, so we better crack on. It's Friday, the 10th of March, 2023, and this is the Hot Topics Podcast. Welcome to the Hot Topics podcast from MB Medical. My name is Neal Tucker. Thank you for joining us. This podcast is absolutely packed today. We are going to be talking about the latest news. There's so much to talk about. Pensions, contracts, key GP statistics. Of course, we'll have our research, and today there's a bit of a theme around antibiotic prescribing and urology. So a BJGP paper on antimicrobial stewardship strategies, one on nitrofurantoin for male UTI, and a New England Journal of Medicine paper on thiazides for kidney stones. That urological theme also continues into today's interview, the next in our series of Just One More Thing. So today that's in conjunction with Prostate Cancer UK, and I'll be talking to Dr Sam Merriel, who is a GP, also a cancer researcher, and has a big focus on prostate cancer. Lots going on in the world of MB Medical as well. So we've just started our Spring-Summer 2023 Hot Topics course. The first webinar we did was last weekend. I'll be doing another one live this Friday. That's the 17th of March, depending on when you're listening to this. This Friday could mean a whole world of different things. Also, Tuesday night, so that's Tuesday the 14th, we are running a free NB clinic, and this time we're doing safeguarding, a topic around domestic violence. That's run by our safeguarding presenter, James Booth, and I'll be facilitating that one. So that's looking to be a good night. Check out the website. There's loads more going on. And don't forget, if you haven't come across it yet, do check out MB Plus. That's our subscription service for just over £300 a year. You get to come on all of our live webinars and loads more, or watch them on demand. And there's loads more in the website, things like safeguarding, BLS, and online learning modules. Do check it out. Right, on to the news. And the first topic is this RCGP Key Statistics and Insights paper that got published a few weeks ago. This is what I was alluding to in the song at the start of the podcast. I think that the RCGP have been doing a pretty good job over the last couple of years. They've been quite high profile in the media. They keep hammering home the message about what general practice is doing and the pressure it's under, and also publishing important data like this. So if you are feeling strained in your practice, I'm sure there's almost not a single person working in general practice now who isn't, then this very simply explains why that is. So firstly, we've got GP workload. In 2022, GP staff delivered 339.5 million appointments. That is 9% more than in 2019, so 9% more than pre-pandemic. That's a big difference. The number of patients per GP as of December 2022 is 2,269. That's an increase of 16% since 2015. That's a big difference. Patients aren't getting any easier, they're getting more complex. And GP numbers are going down. Since 2019, there has been a 6.7% decrease in fully qualified full-time equivalent GPs. Why in general are GPs not working as much? I am included in that group. Well, perhaps the survey on GP experiences explains it. Over 2/3 of GPs say they don't have enough time in appointments to adequately assess and treat their patients. 2/3 of GPs say they don't have enough time to build patient relationships that they want to deliver quality care. And 2/3 of GPs say that patient safety is being compromised because appointments are too short. The RCGP then have done a good job of setting out the scope of the problem. What is the solution? Well, that comes down to government. But if you are in England at least, then it's likely that you will be disappointed with the level of help on offer. The 23-24 GP contract predominantly focuses on patient access. There is no doubt that patient access is a problem. It's a problem throughout the whole of the UK. There's not enough GPs. And there's too many patients with too many problems. Lots of practices have introduced caps to their workload as a mechanism of protecting their own staff and arguably protecting the safety of the patients. At least, of course, the patients that can get seen. The patients who can't get seen, well, that's the troubling area. Troubling for me, troubling for many of you out there as well. Troubling for our patients too, of course. So when the government says, let's focus on access, you might hope that they have some ideas about how we can improve access. You might hope that they would have some additional funding to support any of their strategies. But in fact, their approach seems to be, just do it, which isn't very helpful, because if we could just do it, we would have done it. No one likes patients moaning at us. None of us want our patients to be unsafe. But they've pulled the impact and investment fund funding out from some relatively sensible indicators and just put all of that into just do it. The main concepts that's come up is that patients should be offered an assessment of need or signposted to an appropriate service at first contact with the practice. Does this mean that receptionists should be making an assessment of need? Or does this mean that we need to sack all our receptionists and clinicians need to be answering all the phones? Or does it mean we just need an answer phone message signposting people to 111, don't go there, A&E, try not to go there, or directly to your MP's constituency office? While access is irritating, the big bugbear is, as ever, money. And as inflation is over 10%, the increase in practice income is going to be around 3%. The increase in staff salaries is going to be just over 2%. It's dramatically behind inflation. And this is what's prompted calls for industrial action. Of course, half of the NHS is going to be on strike over pay and conditions over the next few weeks. Will GPs join them? Well, they've been talking about industrial action for a very long time, but the big difference between GPs and junior doctors or paramedics or any of the other groups that are striking is that we never seem to be able to get a group of GPs to agree. Not just agree to striking, but just agree in general. You've got your partners, you've got your salaried GPs, you've got your locums, you've got other GPs in other roles. And clinicians in each of these groups will have their own reasons why they're in that role and not another. And there will be pros and cons to that role. And that makes it very difficult for us as a group of people to agree on a course of action. This is merely an observation. I do not have any solutions. What I do have is some new research. Let's kick off then with the British Journal of General Practice and another great edition, thought-provoking, timely. There's good research. There's lots of good editorial and opinion pieces as well. It is well worth having a look at. The editor-in-chief this time is highlighting the extraordinary challenge of antimicrobial resistance. This seems to have dropped down the agenda a little bit. Of course, we had the pandemic and we needed to think about the immediate. There's been a big focus on climate change and the impact of that on the world and on health. But antimicrobial resistance is an equally important problem. In 2019, there were 1.27 million deaths as a result of drug-resistant infections. That's quite a high number already, but that's going to go up, they reckon, by 2050 to at least 10 million per year. People potentially dying from simple infections because the current treatments are no longer effective. Of course, healthcare alone, and particularly primary care, is not going to be able to solve this problem by itself. It's going to need governments coming together around the world and funding the development of new antimicrobials. And it needs to have, but also, as the BJGP points out, reform to agriculture and aquaculture and how antibiotics are used in these industries. General practice does have its part to play. 70% of antibiotics in England are prescribed in or by general practice. To be honest, given the fact that we see the vast majority of patients in the NHS, actually that figure to me doesn't sound too bad. But we've been successful at reducing antibiotic use over the years. So between 2015 and 2019, the rates reduced by 7.5%. Okay, it's only 7.5%. That is no magic bullet. That's why none of us will have escaped the idea about antimicrobial stewardship. Now that brings us on to our first piece of research in the BJGP, and the title of this is Implementing Antibiotic Stewardship in High Prescribing English General Practices, a Mixed Methods Study. So as the authors point out, there are a number of proven effective antimicrobial stewardship interventions that exist. So ones that have reduced antibiotics prescribing in trials include education-based strategies for GPs, point-of-care testing, use of delayed prescriptions, training in enhanced communication skills for clinicians, audit and feedback, and clinician reminders. Given all of those, getting antibiotic prescribing down should be easy, right? Well, you can lead a horse to water, but you cannot make it drink. In this study, they recruited 9 high-prescribing practices, and they had access to 3 interventions, so enhanced communication strategies, delayed prescriptions, and point-of-care CRP tests, which they used for 12 months during 2019. They then compared the rates of antibiotic prescribing before and after to see if there was any change. They also, and this is the really good bit of the study, they interviewed individual GPs in the practices to find out what were the potential pros and cons to implementing some of these strategies. This is the real strength of primary care qualitative research. This is how you get to the bottom of problems. And problems there were because at the end of the study, there was no evidence that these 3 antimicrobial stewardship strategies affected prescribing at all. Where did it go wrong? Well, the training was on a website, but that had a lack of engagement. We've all had our souls sucked dry doing Blue Stream online training or something equivalent where we spent 20 minutes of our life outside of our usual work time, inevitably being told about manual handling. Delayed prescription seems like an easy concept for people to get on board with, and yet even here there were problems. Sometimes that was patient factors, clinicians just feeling that their patients really wouldn't be able to Maybe they get angry. Maybe they just go and get their prescription straight away anyway. And then point of care tests. Now, loads of us like the idea of point of care tests. I'd love to be able to, let's just quickly test this. Let's just quickly test that. Let's get an answer right now. It sounds absolutely fabulous. But it turns out in reality, when you stick a CRP point of care machine in a practice, basically no one uses it. Appropriate training was a barrier. I also think that probably time, fitting it into a consultation, perceived a value of doing this test in addition to clinical judgment. I feel all of those are likely to be barriers. And interestingly, they also talked about mission creep. So while clinicians rarely did a point of care CRP for cough, which is the primary reason to do it, they were using it for other reasons like testing for polymyalgia. I think that's a great idea. Wouldn't that be fantastic if you get an answer there and then? Great, you can start some steroids right now. That would be pretty neat. Also, someone used it for trying to rule out septic arthritis. I'll be honest, clinically, I'm not sure that's the right way to rule out septic arthritis, but I do quite like the idea of GPs hacking the system. There were common themes that came out that were barriers to implementing some of these ideas. So things like the simply priorities, time, headspace, availability of resources, good guidance, easy access to tools, knowledge, drive, enthusiasm, personal beliefs within the patients and in the clinicians as well. And I think of it a bit like an assault course. So there's all these different hurdles, all these different types of equipment and things that you've got to jump over to finally get to your goal, your destination. And all of these are little hurdles that people have to get over. And individually, none of them are necessarily insurmountable, but together they become much more challenging. And in my mind, others will disagree. Please do get in contact. But on this assault course, in my mind, the very first challenge, the very first piece of equipment that people have to get over is a massive wall, massive, no handholds, no one knows how to get over it. After that, all the other things are like a scramble net or walking through some slightly sticky mud. But this is a massive wall that people can't get over, and that wall is called time. I don't know if there's such a thing as perfect general practice or a perfect GP, but I'm pretty sure if we all had more time, we could be as good as we could and want to be. The paper concludes that clinicians need detailed information on exactly how to adopt AMS, antimicrobial stewardship strategies. My take, they need the time to be able to read that detailed information. And then they say remote one-sided provision of these strategies is unlikely to change prescribing. You got to take people along with you. You got to make them believe. It's just a shame that it may take this existential threat to become much more of an everyday occurrence to make that happen. Now, part of good antimicrobial stewardship is not necessarily just never using antibiotics, but making sure that you're using the right antibiotic in the right person. And the second study we're going to have a look at in the BJGP is nitrofurantoin failure in males with an uncomplicated urinary tract infection, a primary care observational cohort study. This actually comes out of Dutch primary care, and their national guidelines recommend nitrofurantoin as the first-line antibiotic choice in males with an uncomplicated urinary tract infection. Of course, in the UK, we've got nice guidance that has either trimethoprim or nitrofurantoin as first-line options. What's the issue of using nitrofurantoin in men with UTI? Well, it's because it doesn't penetrate into the prostate almost at all. And some experts would argue that if a guy has got a UTI, there's always prostatic involvement. Not everyone would agree with that. I don't think that's confirmed in any data anywhere, but that's one of the reasons why they're doing this research, to see what the level of treatment failure is in this group of guys when they use nitrofurantoin. So they looked at 6 years of data up to 2020. They included almost 7,000 men and 10,000 UTI episodes. Nitrofurantoin was prescribed just over half of the time for uncomplicated UTIs, followed by Cipro, coamoxiclav, and then a combination of trimethoprim and sulfamethoxazole. That's a tricky one to say. It's always interesting when different countries use antibiotic combinations that we just don't have access to and never use in the UK. Only a minority of the prescriptions were for trimethoprim alone. The highest rate of treatment failure was in nitrofurantoin at 25%. Actually, trimethoprim had the same failure rate, but there's much wider confidence intervals there because the sample size for trimethoprim was really very small. Failure rate for Cipro was much better at only 10%, and also for coamoxiclav at only 14%. What does all of this mean? What should we do with this information? Well, the authors of the paper don't have all the answers. They, in fact, call for a randomized controlled trial on the best antimicrobial option for men with uncomplicated UTI. I think there's a few things that we can pull out of it. Why not use nitrofurantoin? Well, renal dysfunction and poor prostatic penetration are issues. Why not then just use trimethoprim? Well, you've got higher resistance rates, whereas nitrofurantoin is quite resistant to antimicrobial resistance. Why not use Cipro? Everybody knows why we shouldn't be using Cipro. For me, this just highlights the difficult balance that we face in general practice. And when we're seeing this group, I think maybe we just need to be mindful about A, making sure we do send that MC&S, try and get those sensitivities. B, make sure we're safety netting. And C, when men then come back to us, keep an open mind. If they're telling us that they're no better, there's actually quite high rates of treatment failure in this group. Last piece of research, quick piece of research from the New England Journal of Medicine. I say it's going to be quick for us. It probably took the authors years and years to do this study, but this was hydrochlorothiazide and prevention of kidney stone recurrence. This maybe piqued my interest because I was out to dinner the other night with a friend and she'd had a kidney stone a few months ago and I'd completely forgotten about that. And she'd been really mindful about what she was eating and drinking to try and prevent a stone coming back again. She was in that phase where we all go like after you've had a big night out drinking, you've got a hangover. I'm never going to drink again. She's like, I'm never going to have peanuts, chocolate, rhubarb and spinach again. Apparently that's a thing, but honestly, I can't see that lasting through Easter. Anyway, nice guidance suggests if you've got a calcium stone that you can consider a thiazide diuretic to reduce recurrence. It'll probably give you gout instead, but given that renal stones are meant to be one of the most painful things that can happen to a person, that and having to hold your wife's hand throughout childbirth, I can empathise with why someone might want to have a treatment to reduce their risk of recurrence. So this was a double-blind, randomised controlled trial in patients with recurrent calcium-containing kidney stones, and they either had various doses of hydrochlorothiazide, so 12.5 milligrams, 25 milligrams, or 50 milligrams once a day, or placebo. The primary endpoint was recurrence of kidney stones, and they recruited 416 patients, followed them up for a median of 3 years, during which time 59% of the placebo group got another stone. That's quite a high amount, isn't it? That's disappointing news if you've had a previous kidney stone. But even more disappointing is that the treatment didn't really do much. So in the lowest dose, exactly 59% of them also had a kidney stone. In the highest dose, 49%, but that wasn't statistically significant. It's a relatively small sample size, I suppose. Unfortunately, hypokalemia, gout, new onset diabetes, skin allergies, and increases in your creatinine levels were all more common if you'd received the medication than placebo. Is this a class effect? Is it the same for thiazides that we more commonly use in the UK? Well, I guess we don't officially know that, but this study is definitely not a great endorsement for thiazides in general. And I think probably the best thing for my friend to do is just keep drinking lots and go easy on the spinach. Okay, that's enough of the research. Time for the next in our series of Just One More Thing. And for today's interview, I'm talking to Dr. Sam Merriel, who's a GP and an academic who particularly focuses on cancer work. Today, he's going to be talking to us about prostate cancer. And this interview is brought to you in collaboration with Prostate Cancer UK. You'll remember we've done a little bit of work with them before. You may have seen our free evening NB clinic a few months ago. If you haven't, then I'll put the link to that in the podcast description. Also links to some of the research that Sam's talking about and links to some of the really good resources from Prostate Cancer UK. Sam, hi, how are you?
Good, thanks, Neil. Thanks for having me on.
No, my pleasure. Thanks for joining us for the ride today. So I'm going to let you introduce yourself. So maybe tell the listeners a little bit about yourself.
Sure. So hello to all your listeners out there. My name's Sam. I'm a GP in the northwest of England. And as you said, an academic clinical lecturer at the University of Manchester. My research is mostly focused on the early detection of cancer in primary care. And a lot of my research does focus in on prostate cancer. Hence why I'm here to talk to you today. I have some involvement with Prostate Cancer UK in an educational capacity, so doing some talks and seminars and podcasts like this for them to help GPs wrap their head around all the challenges we have with prostate cancer diagnosis.
So you'll be very familiar at home now with the way that this works. We've got our 3 questions. What one thing do we need to know about in general practice that's new regarding prostate cancer? What's one thing that we need to know about what's going on in secondary care relating to prostate cancer? And then question number 3 about what is going to be changing the future or pushing the boundaries of managing this condition. Question number 1 then. Tell me one thing that we need to know in general practice regarding prostate cancer.
So I think the most important thing GPs need to be aware of is that the guidance for prostate cancer detection as it relates to primary care has recently been updated. And that's both the NICE Guidance 12, NG12, the Suspected Cancer Recognition and Referral Guidance that we're all very familiar with, and that drives the 2-week wait referral pathway in the NHS, but also what's called the Prostate Cancer Risk Management Program, which relates to asymptomatic PSA screening. So I'll take both of those in turn. So NG12 and NICE reviewed the guidance and the latest evidence in 2021 and published an update specifically to the prostate cancer section of NG12 at the end of 2021. And the main change was that they actually put some numbers around age-adjusted thresholds for PSA testing. NG12 still relates to symptomatic presentation. So if you see men with symptoms that may relate to prostate disease, their lower urinary tract symptoms, hematuria or new erectile dysfunction, it says consider doing a PSA test. And prior to 2021, the guidance said use age-adjusted thresholds, but didn't put actual numbers on it. And there's been good research to show that that created inequalities and variation in practice across the NHS because different regions were using different PSA thresholds. So NICE reviewed the evidence, which was sparse at best. I can summarize the 300-page evidence document that says there's no primary care-based research, and this is all inferred from screening studies and secondary care studies, but they did their best estimates to put some age-adjusted thresholds on PSA levels, and that's in the NICE guidance. There's a table there. You might well start seeing that in your local pathology reports. When you get your PSA results back, they will potentially add in the thresholds depending on the patient's age, and those are the thresholds at which triggers the 2-week wait referral for further investigation for men with symptoms. As many people are aware, the National Screening Committee of the UK does not currently recommend prostate cancer screening based on PSA. And they most recently reviewed that evidence in 2021, and they still hold that conclusion, although they, looking into the future, see some tests that might come on board. There is a back door, if you like, for men to get opportunistic PSA screening through what's called the Prostate Cancer Risk Management Program, which also updated their guidance for GPs and published that in May last year. And they don't advocate age-adjusted thresholds for asymptomatic screening. And actually, the updated guidance is a very woolly reference to what your thresholds should be. It used to explicitly say 3 or more for men 50 to 69. Now it just says if men have a PSA of less than 3, they're unlikely to have prostate cancer. So it's got a bit woolly, and it's a bit tricky to navigate. And I think it's unlikely, having spoken to colleagues, that any of your 2-week wait referrals in your local area are going to specify, did this man have symptoms or not? What's the PSA? Are we going to apply different thresholds? So that's causing a lot of concern that asymptomatic screening is going to be based on what's recommended for symptomatic thresholds. Key message is guidance has changed. There's clear thresholds now from NICE for symptomatic men, whereas the screening thresholds have become a bit more woolly, and it might be worth talking to your local friendly urologist if you're ever unsure about a man and their risk.
It feels like it's a problem that should be quite straightforward, but actually I think this has always been a slightly messy area for us in general practice, even down to when is it screening? When is it actually a symptomatic presentation? Because, of course, we know that most men over a certain age will get some degree of lower urinary tract symptoms. And the vast majority of the time, if you test them, they turn out to have cancer, then it's probably not the cancer that's causing those symptoms. They're probably just incidental. So it's really hard to know. And I think this has always been a bit complicated. When is it screening and when is it a symptomatic presentation? But I guess in some ways, maybe it's better that actually it just doesn't matter too much for us. Here we have a person, here we have an age-adjusted threshold, and if we're above that, do we keep it quite simple and just say, this person needs a referral?
Yeah, it is tricky. You're absolutely right that the link between symptoms and prostate cancer is unclear, is tricky. There's people that have very strong views about whether early prostate cancer, which is what we're aiming to try and detect, actually has any symptoms or not, although the research evidence doesn't quite clearly bear that out either way at the moment. And yeah, we need sort of other tools to sort of help us pick that up. So, I mean, you can look at a man's risk factors. That's the other thing we can look at. So age drives prostate cancer risk mostly. So the older a man is, the more likely they're to get prostate cancer, particularly starting from age 50. Family history is really important. So if they've got a first-degree relative with prostate cancer, their risk is increased. And ethnicity is another really important factor. So we know that black men have twice the risk of getting prostate cancer compared to white men, and twice the risk of dying from it. So you might have a lower threshold for how you investigate, what you do about screening with those men who have risk factors. But if you've got a low-risk man that doesn't meet any of those sort of risk factors, then you might reconsider, or talk to them about pros and cons of doing the PSA test and what happens next.
Yeah, so we're kind of transitioning slightly from a screening scenario more to a almost case-finding, targeted screening, I suppose you might call it. And the difficulty for us is developing mechanisms by which we can identify those who are at higher risk. Actually, our computer systems will already tell us who is at higher risk. The idea would be to start inviting them down more frequently. But then, of course, that goes against the general principle of what we're sort of being told in terms of don't proactively screen people.
Yeah, well, yeah. So that has always been the suggestion from the guidance that is available, is don't be proactive about it. However, in the current PCN contract, there's a DARES around prostate cancer diagnoses, and it does actually encourage practices to be proactive in identifying high-risk groups. Prostate Cancer UK have some resources to help practices if you're interested in looking at this and you want some help with this. They've worked with some practices who've followed the DES this year and evaluated that approach. And it's partly been driven by the impact of the COVID-19 pandemic on prostate cancer diagnoses, because they fell off a cliff like a lot of diseases did, a lot of cancer referrals did, but prostate cancer has been the slowest by far to recover. And got to the point where there was 14,000 fewer men being diagnosed than would be expected based on long-term trends. So Prostate Cancer UK and the NHS got out there to try and encourage men to come forward, talk to their GP. They published their risk checker, which is there for men to have a look at if they want. The balance is shifting on that sort of, should we be reactive and only talk about it if a man comes to us, or should we be proactive in identifying men at our practice who might benefit from these conversations? And part of that also relates to your next question about what's happening in secondary care.
Well, let's go there then. So let's do question number 2 then. So tell me one thing that we need to know about that's going on in secondary care in prostate cancer management.
Yeah. So the thing that GPs should be aware of is that the diagnostic pathway for prostate cancer has completely changed in the last 5 years. So we're all very familiar with these massive screening trials that went on in the 90s and the early 2000s. They do a PSA test, and then a man goes for an ultrasound-guided prostate biopsy as the diagnostic test. Now, trust biopsy is essentially a flip of the coin. The sensitivity, that's 50%. So it's a random sample of the prostate. The ultrasound's not sensitive enough to identify areas where cancer is likely to be. And that means that it misses a lot of cancers as a test. It does pick up a lot of cancers, but it can also pick up a low-grade cancer on one side of the prostate and miss the high-grade cancer on the other side of the prostate. So it's not been a brilliant test. And that's partly why the screening trials didn't clearly show that the benefits of PSA-based screening programs outweighed the harms. One of the big tests that's changed that is prostate MRI. NICE guidance changed in 2019, and now all men who are referred on the 2-week pathway from us with suspected prostate cancer are recommended to get what's called a multi-parametric MRI of the prostate. Now, it's called multi-parametric because it uses the MRI scanner to take different views of the prostate. They put all that information together, and a radiologist basically says, on a scale of 1 to 5, how likely is it there's cancer here? 1 being, this prostate's completely normal. 5 being there's probably prostate cancer here, you need to biopsy that bit over there. And there's a threshold now of, I think it's 3 or more for men to go forward for biopsy. Now, this has been studied in big UK trials, big European trials, and it's clearly showed if you do an MRI first, you can safely avoid a biopsy in at least a third of men. And you won't be missing, you're unlikely, there's no perfect test, but you're unlikely to miss significant prostate cancer, the ones that are aggressive, that need treatment, and that will potentially benefit men in the long term. The other beauty of MRI is that the clinically insignificant cancers, those ones we worry about that are being overdiagnosed, that are not going to affect a man in the long term, don't get picked up particularly strongly by MRI. So it's a really good sort of filter test for men who get referred. And that's being used widely. It's being rolled out across the NHS. Coverage is not 100% yet, but it's getting there, and it will change things in the future. The biopsy approach is also changing. So whereas trust biopsy used to be the standard, it's no longer the standard biopsy in the NHS. So we now go for what's called transperineal biopsy. The needles pass through the perineum rather than through the bowel. So there's lower risk of things like sepsis. They can access all parts of the prostate a bit better, and they can now do it under local anaesthetic, where transperineal biopsies used to have to be done under general anaesthetic. They can now do them under local in an outpatient setting. MRI is filtering out some of those men that might get overdiagnosed. The biopsies are getting safer and more accurate because they've got the MRI information. The urologists and radiologists are doing targeted biopsies. So, they look at the, right side of the prostate and they go, right, I'm going to biopsy that bit. And the studies have also shown they're more likely to get better biopsy results that are more accurate, and they can do fewer samples. So because that secondary care part of the pathway is completely changed, there's a lot of people that believe that risk and benefit ratio of screening, of testing men where, we're not sure what exactly is going on here, has changed, and that the harms are less, and that we can more accurately diagnose the men we need to pick up early, and the men who are very unlikely to have significant prostate cancer won't even get to biopsy stage.
That leads us on to the third question, which is, tell me one thing that's then pushing the boundaries of managing prostate cancer.
Yeah, so I think still sort of staying in spheres that are related to us as primary care practitioners, I think, Neil, in your and my lifetime, prostate cancer screening is going to happen. And it might be when we get to the age where it's relevant, it's actually happening, which would be great. And it could be MRI based, So there are some people that are saying, well, you've got an imaging-based screening program for breast cancer. Why not do it for men in prostate cancer? And get an MRI at 50 or 55, and then if you've got signs of it, you go and get tested. And if you're low risk, maybe you have another scan in 10 years or something. Like, there's lots of conversations going on about alternative ways of screening for prostate cancer. In Europe, they've recommended to EU nations that they start implementing nationally based prostate cancer screening, either PSA plus the European risk calculators that have been developed and refined over the recent decades, or adding in MRI. So there's a lot of moves afoot to push that forward. And as you say, we're in this kind of limbo in the UK, or this transition period, and I expect in the next decades to come, prostate cancer screening may well become a reality.
Do you think then we'll sideline PSA? If we've got enough MRI machines, we won't need PSA at all in that screening context, because we know that's been one of the big limitations for prostate cancer screening so far. Or do you think that we might end up getting some other better, like blood-based biomarker?
I don't think PSAs will go out of practice completely. If you have a PSA of less than 1, the chances of having a prostate cancer are still pretty low. They're not 0, but so it can be used as a filter test, but you need a really good follow-up test like an MRI to sort of filter out those men where it's a false positive on the PSA, which we know that happens a lot at the moment as we use it now. There's lots of interest in lots of other tests for prostate cancer. The genetic side of prostate cancer is also advancing very rapidly. So, there's talk of using genetic risk scores, so adding in all the different mutations in your genome that confer risk for prostate cancer and identifying men at high risk, and then doing some kind of risk stratified approach to prostate cancer testing and screening. So that might well come in decades to come. And the NHS is very keen on implementing genetic and genomic testing across the board, not just for cancer, but for lots of conditions. So I think there's a lot of exciting potential in prostate cancer screening and early detection in the future. And it's more about how we're going to best implement these technologies and refine them to maximize the benefit for men.
Thanks so much for joining us. I'm going to put in the podcast description some links to the Prostate Cancer UK website. They've also got an interesting risk tool that patients themselves can do. The neat thing about this tool is that it also comes with built-in prostate cancer risks information about things. So counselling, which is something that often we end up spending a lot of time doing in general practice. Well, this tool got it all incorporated into it. Sam, thanks.
You're welcome. Thanks, Neil.
Boy, this has turned into a bumper podcast. I hope you've enjoyed everything we talked about today. Hope you've enjoyed the interview. Remember, you can always get in touch. So our email is hottopics@nbmedical.com. You can find us on Twitter @GPHotTopics as well. And don't forget to check out the website for the brilliant things that's going on with NB Medical. Thank you so much for listening today. It's been great to have you along. We'll see you next time. Bye-bye.